Hey folks, sunny day here in Halifax, still lots of snow, still fairly cold. Just a quick video explanation of a post on Twitter. This is the ABCs. When I think of my approach to somebody who's sick, who needs airway management, what's important is that I clearly have a plan and that's practical. It starts out with what I call the preparation ABCDEs, and the A again stands for ask for help. I'm never too proud to do so if it's appropriate for the particular case. The B is breathe, is something it's looking after myself. Again, I'm going to try to control my breathing, try to bring my anxiety down. C is about communicating your plan. So you can have the best ideas, but if it's only in your head, it's not really helpful to anybody else. D is delivery of oxygen, and so we're going to pre-oxygenate the patient. We're going to prepare them for apneic oxygenation with high-flow nasal prongs. The E is what I call the error radar. So there are common things, common mistakes that happen during airway management. They need to be in the forefront of your mind to not to necessarily avoid them, but to have a plan to deal with them. So let's move on to this. So how would I execute this? And I'll just, again, pretend I'm in the room. I've got a patient here, and I say, okay, folks, this is the plan. This patient needs to be intubated for a reason X, Y, Z. My plan A approach is that I'm going to use a direct laryngoscope. I'm going to use a bougie. Nobody do anything with the neck unless I direct them. If that fails, really depends on our ability to face mask ventilate this patient. So we're going to use a two-person approach, an oral airway. If we can face mask ventilate this patient, we've got time. I'll use my plan B, and at this point I think my plan B is going to be video laryngoscope X, a glide scope. Now if we have trouble at any point and we can't oxygenate this patient with face mask ventilation, then we're going to move to our plan C, and essentially that means that we might be cutting the neck. So I might be moving to the neck, but we're going to give a quick try with our supraglottic airway. We're going to use the LMA Supreme size 4 on this patient. But if you see me pulling this out, if we're pulling this out, we all need to know where we're potentially going, and that's cutting the neck. So that's my plan A, my plan B, my plan C. And really, airway management is there are only two directions. One is a you have time direction, and the other one is a you have no time direction. And they're both defined by your ability to oxygenate that patient, usually with face mask ventilation. And that's the same way with devices. There are only two groups of devices that are out there. The you have time devices. Those are the alternatives to intubation, video laryngoscopes, other indirect approaches, and then you have no time devices. And really we're talking about supraglottic airways, and preferably the second generation supraglottic airways. And lumped into that, we lump into the you have no time devices doing a surgical airway, because cognitively that's where your brain needs to be. You need permission to proceed if it's indicated. So that's my ABCs, and that's the way I try to articulate it whenever I've got a case in front of me. I'm going to repost that little diagram that I did last night during a night shift. Thanks for the feedback I received. Have a great day.